thanks for joining me today. I really appreciate it. Employers are, as we know, the second largest purchaser of healthcare in the country, right after the government, and DPC is the solution for a healthier workforce. So we're trying to bring together employers and DPC docs to create a better healthcare system that will improve outcomes and lower costs. And today I'm so honored. Thank you so much for joining me, Dr. Shane Purcell, one of the legends in DPC and author of Magic, Pixie Dust, and Miracles, a guide for direct primary care and employers. Welcome, Shane. So grateful to have you here today. Thanks for joining us.
Thanks a lot. It's going to be fun. Let's do it.
Yeah. Okay. So first, I just have some questions. Like, what first inspired you to start working with small businesses?
Well, it's if you talk to DPC doctors, a lot of times they fall into working with small employers. Basically, because everybody that comes to your clinic, they all work somewhere, and a lot of times you'll have, a guy who owns a plumbing company, and he's like, "Man, I really love your care. I want to give this to my employees." So it may be a mom and pop shop or some kind of small business in town that somebody owns, and that's sort of how it fell in for us. And anyone who starts a DPC, I always tell them, be ready for the small employers because mom and pops are going to come. They want you to take care of their patients the way you take care of them. So it's going to happen. So I would just be ready for that. The bigger ones, 100, 200, 500, 800 employees is a whole different ball of wax, what you would have to prepare for. But so we fell into it the same way. As soon as we opened within a few months, these smaller companies were like, "Hey, will you take care of our employees? We don't offer them anything." The small employers less than 50 didn't really offer insurance, weren't required to do it. So for them to pay $50, $60, $75 a month to get really good access to direct primary care was a win for them and for their employees. So within, a couple of years, we had probably 20 to 25 small employers that were using our office for primary care service that were, helping their employees either paying partially some of their monthly fee or paying the whole monthly fee for them to use our services. And then as you grow bigger, your reach spreads out and your things begin to snowball. And then larger employers begin to seek you out as well. And we've had a couple of those, some good, some bad. And some of that depends on, as you said, when you open up, you have to have a really good plan to fit with DPC or it's not going to be really good. So the small employers don't really need a plan. They just want the care. They want the time, the access. The larger ones, those are the harder ones.
Yeah. So in my experience, some of the employers will kind of circle around before committing. Now, if they're your patient, it's a lot easier, right? But when they're not your patient and maybe it's one of their employees that brings them in, they want to know sort of the whole ball of wax, and they want they want the reassurance that there's a wraparound product. And so getting those deals closed, what are some of your valuable takeaways on how to close the deal? Because I noticed they'll circle for a while before they'll commit.
Yeah, it takes time to, like larger employers, if we're talking about people that have an insurance plan or they have to craft a plan with it.
Yes.
So some kind of self-funded plan or a plan that would work with direct primary care. It takes work, so a lot of people don't want to do that work. There's risk. A lot of employers are really scared. Like, okay, so I'm going to be the insurance company. That's kind of scary. But it takes a lot of education to learn about how that works. You have to have a broker, an advisor, someone who's really committed to the process. And to make it work, a lot of really good brokers and advisors will tell you over and over again, you need DPC to be the foundation of those plans in some form or fashion, because cost and access is just going to be greater to be able to get seen and lower cost. So taking your time, it takes a long time. Like our big employer that we deal with is a municipality, which takes even longer because you got to convince the county manager, you got to convince the county council, you got to convince the CFO, you got to convince the county lawyer. There's all these people that have to be convinced. You could have a larger company, where the CEO is your patient, and he has 500 employees, and he could just go in and tell them, we're doing this next week. And that's makes a big difference. But typically, you got to get to the person. I tell people, I wrote this in my book, you got to know who's in the room when you're talking to them about DPC, because that's critical. Because if you're just talking to an HR person and they don't, they know that all they want to do is get a renewal of their Blue Cross Blue Shield and go on to the next thing on their list, they're not going to spend a lot of time and money and energy to try to craft a whole new plan, a whole new broker, a whole new plan for everybody. So it's just, they're just going along to get along, and it's very difficult to turn that ship around. It takes work, commitment. They have to have a lot of courage and commitment to change their entire plan. And that's what the county did. In my book that I talk about the most is that the county basically they were on a state plan for 20 something years, basically a Blue Cross Blue Shield plan, and they just cut it off. They stopped it.
Yeah, I read your book. It was pretty inspiring. Thanks. I was also kind of thinking of the smaller groups of employers who have no benefits, that selling the direct primary care alone is a way to do that for the smaller groups. But when you get into the larger groups who have, like you said, an insurance plan already, and they want to make sure they've got all their T's crossed and their I's dotted, sort of figuring out the wraparound plan for the direct primary care. That's sort of the recipe for financial success in the self-funded world, and aligning those incentives for the broker to make sure that they win when the employer saves dollars, right? And when the quality stays high. So the question is how to align those incentives in a way, because there's a lot of different ways to structure, right? There's a per member per month. Have you seen any other ways of structuring it? Are there any brokers that you've worked with that align incentives such that they get a cut of the savings that they provide to the employer?
Well, I've heard of the brokers advisors doing, percentage savings. Most people are doing, most of the smart ones are just a straight commission. So like, hey, here's what it costs for me to do that work, to do this plan, manage the plan, and help you stay with it. The best brokers are just getting a commission, so they're just doing it that way. And then the other option is, I've heard people say a percentage of savings, but that can be tricky, because if you're, how do you set that percentage of savings? Like, hey, last year with that Blue Cross Blue Shield plan, you spent $10 million. Well, I saved you half of that, so you're gonna have to give me 10% of that half. Well, that's just not going to work, because you can't do it that way. It's very difficult to do percentage of savings, but there are people to try to do that. But the commission is basically, the way that the broker advisors have traditionally worked. I'm going to get commissions from the insurance company, but basically, the best way to set it is you set a standard fee, and here's my fee to set this plan up for you, and it's a yearly fee. You can have little incentives here and there, and the brokers and advisors, there's other ways they get kickbacks besides employers. There's life insurance plans. There's all these other plans where they get little pieces of the money in there. But basically, it should be straightforward, transparent. The broker, you want, just like us in DPC, we go into the room. If you go to my website, it has all my prices listed. It tells you who the doctors are. Everything, how we operate is all listed. So we're not hiding anything. And the brokers, advisors, we would like them to play in that same field. To know how do you get paid? How are you getting your money from your employer? And if they just come in and say, hey, I charge $70,000 to manage these 500 patients, that's how I get paid. And I'm going to take care of you guys. I'm going to get you on the best plans. Then you know where you're at. So that's the only way that I see a good way you want someone that's going to work for you, and you're paying them to do the work. And because if they don't do it, you get rid of them and find somebody else that does it.
Yeah, no, I think that's great. I was just trying to visualize sort of how you could align incentives to control costs, because currently in the BUCA world of broker compensation, it is usually aligned with, like, is it a per member per month, or it's aligned in a way that they get paid more when your premiums go up. I wondered if
Right.
there was a way to maybe align it as the premium, and not as the premiums go down, but as you save money, they generate more revenue for actually providing the value. And so that was just my thought, was that, I think
Yeah. Yeah.
if there was a way to align value, and that kind of goes into my next question, which is sort of, you know, in the future, like in your vision, do you see a world where multiple DPC clinics can work together to provide service for large employers like across the nation? And how would you imagine structuring an incentive, again, to remain aligned to provide value and decrease the cost while
Hmm.
maintaining the autonomy of those independent clinics?
Yeah. I think you're already starting to see some of that now in some bigger, more corporate type groups, I would say. But aligning like independent groups where different areas or even regions of areas, I know there are people who are doing that in small areas already. There's a group of ladies up in Pittsburgh, Pennsylvania that have a small, what we call MSO, which management service organization there, and they're trying to get DPCs to join into that group so they can go individually so they can go to employers and say, hey, we have 5 docs, we have 6 docs, doing DPC. There's a group down in Augusta, Georgia area that sort of has the same kind of thing, that they've grouped together several DPC docs. So I think you'll see more and more of that, to try to go to employers, because they want to cast a wider net. Like, okay, well, we've got this big office here, but we also got one over here and over here, different cities, different communities, and even larger organizations are going to have potentially offices across the whole country. So I think more and more people are trying to figure out ways to do that. Different
Yeah, I
companies are
mean,
trying to
employees
connect.
want choice, right? They want choices,
Yeah,
seeing different doctors, and then the docs really want the autonomy to be able to function independently and not necessarily enter into a network. So I'm thinking of more like a coalition type of thing, right? Where
yeah,
everybody is incentivized the right way to participate, to save the employer money and to provide the high quality care. But I guess I'm still a little hung up on the wraparound product, right? Because that is where the employer ends up losing big dollars if they're going to lose out of a self-fund bucket when somebody goes into the ICU. And so
right.
just sort of like really aligning incentives on that side to make sure that we're controlling the cost, because the DPCs are always going to save money. We know that. But
Mm-hmm.
the big spend items like the chemotherapeutic agents that need to be infused weekly, or
Right.
the ICU stays, those are the ones where really it just takes one, and then suddenly the buckets go dry, right?
Yep. Well, there's two things. I mean, obviously, that's where the advisor is going to make that's where they have to do their job to create a really good plan to match up with DPC. And then obviously a really good stop loss insurance, which is the cap that they're going to put on that. And that's sort of, you have to figure out where that is for your company. So if you have 1,000 employees, maybe that stop loss cap is 100,000. If you're smaller, it may be 25,000. If you're a huge company, it might be 200,000. Like, we're not going to pay out any more than that per individual. And there's different ways they can set that stop loss. So stop loss is going to be critical. You got to have a really good stop loss company that you can work with. You got to have a really good PBM that you can work with, because you got your expensive medications, and you got to have a really good TPA that's going to do the claims, that
Right.
understands you're trying to do cost-effective, self-funded type plans.
Yeah, so it's really setting up a whole team around the quarterback, who is the DPC doc, right? To make sure that
Yep.
all along the path, because it's not just in the four walls of the DPC, but it's outside where the dollars can be lost. And essentially that's what turns into the renewals, right? And as much as we don't like churn in DPC, we aren't going to like churn with big employer groups either. So
That's
you're
right.
gonna want to make sure that the incentives are aligned to save money outside of the four walls by creating that awesome team. You're right. I agree.
Yeah,
Yeah.
you definitely have to do that. I mean, And DPC, the hard part is off the ground floor part for DPC is just trying to do the best you can do to take care of every patient the best you can, and using the facilities in your area. Like, you know where the best place to get the MRIs and imaging and maybe gallbladder scans and surgeries and orthopedic surgeries, and trying to get those people to the right places to make
Yeah.
it cost effective.
Yeah, no, that's great. Well, thanks. This has been awesome. Thank you so much for taking your time. Where can people reach out to you if they want to learn more?
The best place to connect with me is Dr. Shane at dpcmagic.com, Dr. Shane at dpcmagic.com. I'm usually checking that pretty regular. You can meet me there, or I'm always on the Facebook page a lot, and LinkedIn, different areas you can find me.
Awesome. Hey, thanks so much, Shane. I really appreciate
All right.
it.
Thank you.